viewers nor PBS El Paso shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
Good evening. With the advancements in medicine and simply taking care of ourselves better and better, we are all living a little bit longer, and isn't that great news? But there are physical complications with aging. We all know that. Sometimes there are mental complications, and that can be very emotional and difficult to talk about. In this next hour, we're going to be talking about mental health and our aging family members who might be in the first stages of dementia, and there's all kinds of reasons why that will be happening. We are specifically going to talk about treatment options that exist here in El Paso. This is a live program, so think of some questions of your own that you want to call us with this evening. The number is 881-0013. This program is underwritten by Tenet, who we all know them as the Hospitals of Providence. And we also want to thank the Texas Tech Paul F. Foster School of Medicine for providing the medical student who is here today to answer our phones. Today we have Madeline Morris with us, and she has wonderful handwriting because she sends the text to me on my phone. So if it looks like I'm playing with my phone during the show, it means I'm trying to get the questions from you all. So thank you very much for calling Madeline, who you just saw there on the air. A huge thank you also to the El Paso County Medical Society, who brings this program to you each and every month. I'm Catherine Berg, and you're watching the El Paso Physician. Good evening. We're here this evening to talk about geriatric behavioral health, and we also want to talk about not just behavioral health, but there are mental issues that we can speak about this evening. We have a returning individual, so you are officially a veteran, and I like that you have an 18-word name. We have Dr. Angelo Mauricio Rodriguez Chevres here, and he is our panel and our psychiatrist this evening.
May I correct you?
Oh, dear God, yes.
Ángel Marcelo Rodriguez Chevres.
Rodriguez Chevres, thank you. Marcelo, can I just call you Marcelo?
Marcelo's great.
No,
That's
just-
how my
I'll
friends
give
call
you-
me, so feel free to.
Well, I'll be your friend this evening.
Okay.
Jacob, can I be your friend too?
Yes, ma'am.
Because we also have Jacob Butler with us, and he is a mental health nurse practitioner in the Geriatric Behavioral Health Unit at the Hospitals of Providence, and you are at the Memorial Campus.
Yes, ma'am.
So thank you so much for being here. And Marcelo, I can't call you Marcelo because you worked hard for that doctorate degree, so I'm going to call you Dr. Rodriguez Chevres.
Wow, you did that well.
I'm trying. As a psychiatrist, what do you do all day, every day? Because there are some practitioners that take people in their office, medications, this and that and the other. So when people are thinking about asking questions to this program, give them an overview of what you do every day.
Wow, might take us the hour.
Yeah, it might take us the entire hour.
I'll
That's
give you
okay.
the short version.
I'll stop you 15
I'll give you
minutes
the short
before.
version.
Okay,
All right.
gotcha.
So because of the pandemic, obviously there's a lot of remote work. So I'm doing quite a bit of clinics from there, including the Emergency Health Network. We also provide services for the jails.
Okay.
So I do that. I do our clinic on the West Side Clinic. I supervise all our nurse practitioners and PEAs, attend all kinds of meetings having to do more with the administration clinically of those providers, as well as strategic planning and that sort of thing. And I obviously round and supervise as well the nurse practitioners over at the Geriatric Behavioral Unit at Providence.
Okay. And so the Geriatric Behavioral Unit, we're going to talk about that too, because I know Jacob is involved with much of that. But Jacob, and it's easy for me to ask you what you do all day, every day, and it's very difficult to put that in a small package. But take a couple of minutes to explain to the audience what you get to do every single day.
I get to work my butt off for Dr. Rodriguez Chevres. That's what I do.
Blame
Enough
it all
said.
on me.
So-
exactly. So basically, in the mornings, I do round, usually Tuesday, Wednesday, Thursday at the Geriatric Behavioral Unit. And then I go Wednesdays, I don't even know, you see?
Yeah.
Anyhow, Tuesdays and Thursdays, I do see the IDD population here in El Paso, which is the intellectual developmental disabilities, for a couple of facilities here in El Paso. Also, on Wednesdays, I do the partial hospitalization program for Dr. Rodriguez. Like I said, I work. And then
That's a partial hospitalization, is that what you said?
Yes, it's
Okay.
for Emergency Health Network
Okay.
alternatives program where they do half day of hospital or therapy, and I do a lot of the medication management. That's usually Monday, Wednesday, Friday. In the afternoons, I do go see the patients in the annex here in the jail system,
Okay.
Monday through Friday. And
Man, you're everywhere.
yes, I'm pretty.
He's young enough to do that.
Look at this very solemn face he has. I don't know if you can see it. Yes, I am everywhere.
Yes.
So,
Thank you for reminding me. Yes.
Yeah. And then on the weekends, I have to go work with him sometimes. So.
Oh gosh.
Yeah.
Does he ever invite you over for barbecue? or anything?
I've been in his house twice, right? Twice,
Yeah.
yes. So
I've been to his too.
All right, just
All right.
checking. Just
we
checking.
hang out every once in a while.
We are focusing tonight. So both of you all do mental health issues for all ages, but tonight we really want to focus on the population of 65 and plus, because there are 14 hours of shows that we can do on mental health issues, and I like that we take some of these pockets sometimes and really do a deep dive in some of this. So when we're looking at 65 and older, and people just think of mental health or dementia, automatically the Alzheimer's word comes up. And, oh, it must be Alzheimer's. And that's not necessarily the case. So I would love for you, Dr. Rodriguez-Chavez, if you can describe the declining of just mental health in general, and when dementia sets in, what can be some of those causes? And I know sometimes we don't know, but
Correct.
just the idea of what some of those causes could be.
Well, let's start with we don't know.
Okay.
Because actually you mentioned dementias, and oftentimes the Alzheimer's comes to mind, which is actually a diagnosis of exclusion, meaning that if the signs and symptoms that fit criteria for dementia are not found elsewhere, you basically call it Alzheimer's.
I see.
And it is the most common because most commonly we don't know. We suspect, that's why in the diagnosis category, which by the way, now is more related to neurocognitive type of, that's the actual term.
Okay.
That's where they all would fall in. So if you don't find somebody had, I don't know, vascular dementia, for instance,
Right.
related to multi-infarcts, strokes, and so forth, we call it vascular dementia.
Right.
If somebody abused alcohol all their life and actually developed those signs and symptoms of dementia, we refer to alcoholism at the cause. Is it
see.
Parkinson, Huntington's chorea? Those are
Right.
more rare. But really, it's good to clarify because I get that question, or I see the patient's families and significant others kind of puzzled. Well, they told me it was dementia, and then somebody else said it was Alzheimer's and so
Right,
forth.
right.
And it's kind of neat to put it in that context, in reference that Alzheimer's is the most common type of dementia.
Type of dementia, yeah.
But we don't really know, because to really diagnose it, it's a little bit too late. It's an autopsy where
Right.
you could actually find those neurofibrillary tangles and so forth. We don't want to get too technical. That
But
Dr. Alzheimer's described.
Exactly. And let's talk about Dr. Alzheimer's for a second. But when, and I am going to get technical for just a minute, because
Uh-oh.
again, and you're spot on, and this is what I've heard from many friends of ours, that when the autopsy, what do you see in the brain with the autopsy that shows, okay, yes, this patient did indeed have Alzheimer's, versus a brain that may have been someone who had dementia from whatever abuse, say drug abuse, alcohol abuse, etc. What is it you see with Alzheimer's versus other conditions?
Well, obviously, I'm not a pathologist.
Right.
Sorry,
but you have to play one on
yes,
TV tonight.
well, I will.
All right,
I will.
I appreciate
I
that
think
part.
I have a good explanation for
Okay,
that.
great.
But basically, it relates precisely to how these tissues in the brain cells and so forth, because atrophy could be everywhere. You know,
Right.
atrophy is normal in the process of aging, but then that tend to grow. You know, in any kind of dementia, you would see that. But these neurofibrillary tangles that the doctor
Exactly.
described are pretty peculiar in form and location and shape and so forth. And the other point to actually make clear is that unless you're doing research, you're not going to get a lot of families asking for autopsies.
Exactly.
Because of the age, the multiple conditions they might have had,
And the
pretty
emotion
much,
that goes
and
along
the
with
emotion
it.
that goes
Yes,
along. Why?
Yes. Yeah, exactly.
You know, I mean, if you had a mysterious type of death or whatever, you really need to find out. It's a different matter. But we're clinicians,
Right.
so we obviously don't do that side of it. Nor do we get that request. It would be pretty rare for somebody to die after being diagnosed and treated for any kind of dementia, and then ask for an autopsy,
Exactly.
except if you're conducting research.
Right.
So.
And Jacob, this may be an unfair question to ask you, as it might be something that I would ask Dr. Rodriguez-Chavez, but in the idea, I think of you as the guy in the field. You're the one seeing everybody. And when you, and let's just say with the annex, when you're talking about the jail, so when we have inmates that are in there that are like in their late 60s, in their 70s, and so you get to see people. Are there times when you have a suspicion that they should, and this is where the hard part is, that how do I diagnose someone with a dementia and how do you treat it? And it's a big question, and I don't even know exactly how to go around saying that, but when are the suspicions there? Because I totally have been the girl that have put her car keys in the refrigerator. I've put the dog bowl in the shelf in the bathroom. And so all of us kind of have our moments of, am I going nuts? Or am I really losing it? Am I just not remembering things? So there's that, I'm kind of making fun of it, but I shouldn't. Because we all kind of have that stage of, I'm really starting to forget things. When do people start worrying about that?
When you're 65. No, I'm playing.
There we go.
I play. No, you know what? As a matter of fact, the annex just asked me to assess a patient who is 80 years old, and they're trying to figure out if he has dementia. So what I did on the GBU unit today was ask social services Ana Yancy. Hello, Ana Yancy. But anyhow.
Hello, Ana Yancy.
And I asked her for the MOCA screen, which is a Montreal Cognitive Assessment.
Okay.
That gives us a scoring of anywhere from 1 to 30, but it gives us an idea of their state of dementia, the severity of the dementia. I should have brought it. And then also we have the intellectual functioning that we also do upon psychiatric evaluation, where we ask them for questions related to their recent memory, remote memory, such as what's the president's, or what's today's date, or what elementary school did you go to. And unfortunately, like Dr. Rodriguez said, we can't really, I guess dementia is, if it's asked on a daily basis, and if all the medical causes have been ruled out, then there's a strong likelihood that there's probably some dementia going on.
Okay.
As Dr. Rodriguez said, we can't diagnose Alzheimer's. We can't get a true diagnosis of Alzheimer's unless we do an autopsy, right?
So you're looking at this point kind of clinically what the answers are. And you talked a little bit about the MOCA scale. Is that the scale that you were talking about earlier?
Yes, the Montreal
Yes.
Cognitive Assessment.
Okay, so is that the questions that you were asking just now, where you went to school, who the president is, or is
No,
that
that's
something different?
something different.
Okay.
They'll ask you to do a little crossword puzzle, and then they'll ask you to draw a clock 10 past 11. They'll ask you to name some pictures. They'll ask you to repeat some words, 5 specific words, like velvet face, in about 5 minutes after. And then you score it all together, and then just based on the number of questions that they got right, then you get an idea of how bad their cognitive state is. So if they get 30 out of 30, well, you're good to go.
Right.
Or even, I think, 27, right, doctor? So 27 and up is you're good. So
in assessment processes, would it be, for example, and again, I like talking about case studies without names, but it helps because in your head there's a story, and it also helps the audience see this person's story. So you were talking about this 80-year-old individual who you're asking to assess. So you are doing both the MOCA scale and then other questions too. Is he assessed several times within a certain amount of time frame? For example, asking these same questions within 4 or 5 weeks of one another, or is it just like a one-time thing? Because I know there's bad days and there are good days.
Yeah, exactly.
How does that work?
Yeah, we always schedule follow-up appointments, and then we always ask them, we always check their memory. It's usually pretty consistent every time you talk to them of their cognitive state, and especially in the criminal system, it's very hard to help people with dementia. A lot of the medications that are available in the population aren't readily available in the criminal justice system.
Exactly.
So we have to work with what we got, and but also it's a placement issue. It's hard to place somebody that's in jail and get them the proper help when they're in jail. So So that's, I don't know if I answered your question, but.
No, you
maybe
did, and
Dr.
that's actually, it's a perfect follow-up for Dr. Rodriguez-Chavez, because now we're looking at treatment. So let's say Jacob has been with some people, and let's just say that there is now somewhat of a diagnosis.
Yes.
Just diagnosis of dementia, not knowing what kind of dementia, but there's definitely some issues with dementia. And so, and maybe we can take the annex out of the equation now, but let's talk about any 80-year-old who is having these issues. And definitely they've been scoring lower, say they're in the 15s out of 30 or something like this. Where and how does the process of treatment come in? And I say this also with the caveat, because many older people, and thank goodness, because hopefully their babies and their grandbabies love them, but have care systems around them, have people that are their support systems. Treatment for medication, and then also if we can talk about treatment of what you talk with the families of the person with dementia about, because that's a big game changer right there if you've got people around or not.
Well, it all's going to depend on symptom formation. You know, what are they depressed? Are they crying? Are they aggressive? Are they agitated? Are they psychotic? Do they think the family is against them?
Right.
Kind of paranoia type of thing, which is relatively common. They've been persecuted. They're taking their properties, their monies, their et cetera, et cetera. And this could be a change in behavior that could be acute, but more like all of a sudden. But more frequently, it actually takes time, some changes. And a lot of people focus more on the memory thing, you know, and you're right, just like you, sometimes I wonder about myself. But no, you know, there's particular changes over time that will seem like, this is out of character, or this is getting worse, or confusion in general, you know. You know, going to the bathroom thinking it's the kitchen, or, you know, obviously that might be a little bit more longer down the road. So if there's aggression, agitation, and so forth, you have no option but to use medications. We like not to. And unfortunately, because of that age group, there's not a lot of medications that are actually researched for that population. And what does that puts us in as clinician? Is that we need to consider off-label. Off-label, not because you cannot use it, because it was not researched. So there's no data to back it up, right? So, and traditionally, those studies, unless you really go into the pediatric population and so forth, but traditionally for adults, it's about 18 to 60, 62, 65. So you got a patient that's 88, 90. There's no research
There's not
to
a lot
say.
of research on that. Exactly.
A particular one that concerns us is antipsychotics, because oftentimes you have to give them because they're psychotic. But they're off-label. We shouldn't really be giving them.
So when you say off-label, it means it's something that has been given, but it's not technically, and when I say off-label, not name brand.
Not approved by the FDA.
Okay, not approved by the FDA. So I just wanted to make that clear, that it's not a name brand. So, and this is where it's hard too, and these are hard questions. So I'm going to throw a pretend case study out there. So now we have someone who's 83 and in great physical condition, great mental condition, but then all of a sudden they just start doing what the family would say, just weird things. You know, they're locking themselves out of the house, or they're, you know, like you said, walking into the closet thinking it's the bathroom, etc. So when that starts happening, what does a family member do? And so I'm thinking about people in the audience right now that might be sitting there watching. It's like, well, my mom's starting to do this, my dad's starting to do this. Do I call someone? Who is it that I call, and what do I tell them? Because you also have that idea of mom's going to be very prideful. Mom's not going to want to think that anything's wrong. So there's that dilemma that the family members have. And Jacob, you could probably answer this too. And both of you, I'd love for you to jump in, because I'm trying to figure out, because the person usually who has dementia, they're not the ones that realize that they're having an issue. It's usually family members. So what might be some advice that we can give to the family members if they notice these types of behaviors? And not just forgetting things. You're absolutely right. Where there's mood changes, or all of a sudden they're just mad all the time, or crying all the time, etc. What could you tell the family members? Who are they calling? Are they calling you? Are they going to say, hey, Jacob, tell me what's going on? This is Jacob Butler here.
Well, I mean, the Hospitals of Providence, the GBU unit does, a matter of fact, we've had patients call the unit and ask them for help, and they have very good nursing staff, very good nursing assistants. The unit's very, very well run. They attend to medical needs, they attend to behavioral health needs, and basically we just got to rule out all the underlying causes. For example, UTI can cause delirium.
UTI can cause delirium?
Yes.
Oh, yeah.
Yes.
Okay, that's new to me.
That's a
Yes.
tough connection to
That
make.
is a tough
Yeah.
connection to make. Okay.
So, I mean, we encourage them to go to the emergency room. Once they're medically cleared, then they go up to the unit, the Geriatric Behavioral Unit at the hospitals of province. And then we address the mental health needs of the patient after the medical clearance occurs. Medical always comes first
You're right.
because there's a lot of the thyroid. The thyroid can give you manic symptoms of bipolar.
Oh, that's a whole
yes.
nother thing.
So we
Right.
got a lot of conditions, medical conditions that could cause mental health issues, and so we got to roll all that out before we accept somebody to the unit. And it could just be something simple like a UTI. Okay, we give you antibiotics and you leave, and your hallucinations go away, and your delirium goes away, and that's it. And then if all that subsides and it's still something mental, then me and Dr. Rodriguez and also there's also another nurse practitioner, George Medina, we look into the behavioral health needs of the patient. And the great thing about the hospitals of Providence is that we attend to the medical needs of the patient and also the behavioral health needs of the patient. So if something comes up while they're on the unit, they have registered nurses that are both working on the mental health aspect of the patient and the medical aspect of the patient, and they're there. I know I've worked at other mental health facilities, and for example, if you have a medical problem, somebody's short of breath or somebody's tachycardic, which is increased pulse rate at 150s, the nurses catch it right away. They don't have to call the emergency department or the EMS services, which emergency medical services, and then transfer them out. If there's something wrong with the patient, we transfer them out right away
Okay.
to address their
And
medical
transfer
needs.
them out to the medical, to
To the medical floor.
Yeah,
Okay,
same,
gotcha.
same place.
Yeah.
Okay.
Same place. We've had those situations. Also, the beauty of the geriatric behavioral unit is that a lot of these medications, and it's even harder with the geriatric population. It's harder because their organs don't work as fast,
Yes.
and
Yeah.
the kidneys don't filter as fast. The liver doesn't work as good. So we got to be careful with the meds. A lot of these meds can cause low sodium levels,
Right.
and we're drawing labs to monitor those levels. Some medications require a therapeutic level. We're able to draw those labs and get results within hours.
Oh, that's quick. Okay.
Yeah, so
Right.
we're able to provide IV fluids. We're able to insert Foley catheters. We're able to do all this medical stuff along with addressing their mental health needs. So.
And that's a full gamut too. And Dr. Rodriguez-Chevedes, if I can take it to you with what type of, so it's great, Jacob mentioned thyroid, he mentioned UTIs. What other seemingly benign in the world of mental health or in the world of mental issues, what seemingly benign things could also trigger some issues?
Sure.
So thyroid is one that we can talk about, because there's so many people that have, I'm hypothyroid, for example, so I'm the synthroid girl, have been since I was pregnant, had no idea I was hypothyroid, so, my ears are perking up right now too.
Well, one of the most common things will be dehydration, for
Okay,
instance.
that's
And
a
some
good
of these
point.
patients might not be ingesting enough liquids, water in particular, but any. And not only that, with our weather, exposed to the weather, the sun, some medications actually make them more sensitive. It might be even a matter of nutrition as well. So, and Jacob is completely right. We are all trained, whether you're a nurse practitioner, whether you're a doctor or whatever, you're all trained, you think organic first.
Right.
You have to
right.
rule out that you don't want to assume, oh, is this mental condition, and then neglect to look at all these other parameters you need to follow to have that comfort zone clinically that you're moving in the right direction, okay? I mean, even with behavioral changes, for all we know, it could be a tumor,
Right.
you know?
Good point. Right.
So, or people that have been in some kind of a trauma as well, you know, it's something that affects the brain gradually. It could be even mild bleeding along the way, and you don't know it. The person is behaving quite different, and especially if they already have a psychiatric history.
Right.
And by the way, one does not exclude the other. We call that
Good
comorbid.
point.
And that's
Comorbid, right.
comorbid. So because you have one, it doesn't mean you cannot have the other.
Exactly.
And in fact, my dissertation in my residency, I did it precisely on an unfortunate death of a psychiatric patient, schizophrenic, long-term, showed up to the same ER. They put him over there and took out for the psych resident to come in. The guy was having a heart attack.
Oh my goodness.
And he died right. You know,
oh goodness.
it's
right.
this, you don't want to assume that, obviously, because
Right.
people that have mental conditions are human beings.
Right.
They can have other conditions, you know. And let's face it, to have something wrong with your brain, and that's where the problem is.
Right.
You know, a lot of people think it's more behavioral or whatever. No, the data and the research is quite clear that these are changes neurochemically that they're so fine, and I want to call them even mysterious,
Right.
that they cannot be measured.
Exactly.
So when you can put something on the table and measure it, like I should have been an orthopedic sometimes, I feel, because you know, you could measure, you
it's
weigh
very
it.
mechanical. It
and
all
what-
makes sense. You know, it's like
Exactly.
puzzle pieces you put together with orthopedics.
But
They don't like it when I say that.
no, of course not. But in the case of psychiatry, of behavior, of emotions, and so forth. But think about in terms of what the brain represents. You know,
Right.
you could call it the boss if you want.
Yeah.
Although every part of the body, every organ of the body, obviously has its role and its importance and so forth. But all of those signals are coming from
All
up
from the
there.
brain.
You know, whether
Exactly.
heart beats or not, or whether your lungs are expanding or not. So, you know, when people ask me, well, how much of it is in my head? Well, 100%
it.
of the brain is there.
Well, you hit on something that fascinates me, because neurochemical is what is happening in the brain, and when there are medications and treatments. And I'm just thinking about this day and age, and I'm looking at young people, but also old people, seniors. I'm one of them, so don't get mad at me. When you're looking at antidepressants, for example, and then anti-anxiety, and these are medication, because there's a whole gamut of antidepressants, a whole gamut of anti-anxiety. Sometimes they're somewhat linked together, sometimes they're not. Then there's the ADHD medications, they're out there. So all of these are when I think, you said neurochemical. So when I'm thinking of that, what are some of the most common medications that are being given? And again, mental health with seniors doesn't necessarily just mean dementia. What other types of issues are there? I know there's a lot of depression in our senior population.
Quite a bit.
So maybe we can skew a little bit that way,
Right.
and talk about that and what medications there are, and then what cognitive behavioral help they can have as well, and just some of the services you all can provide.
Well, it's a great question, because really anxiety disorders are the most common disorders if you look at, I don't know, adolescent, mid-adulthood or whatever, you know. But when you go into 65 or over, the group we're talking about, depression actually takes that role. And it's depression and dementia, actually the most common ones. When I talk about neurochemicals in the brain, it's basically that all this body, all our reactions, emotionally, physically, whatever, are actually guided by neurotransmission in the brain.
Right.
It's all about chemistry, right? So, and electricity.
See, and those are the two harder
That's it.
things.
That's it.
Yeah.
So the signals come into our brain so we can operate in one way or the other are electrical. But the transmission of that information from one cell to the other one requires chemicals.
Right, exactly.
And it's complicated, so and I'm not going to make it complicated. It's basically
Well, nobody
brain
hears
cell-
this part of it, so I'm so glad we're talking about it. It's the chemical and the
Yeah,
energy,
yeah.
so to speak, the
Brain
electrical and the
cells,
chemical.
brain
right.
cells cannot touch each other.
Right.
It's called a synapse. There's a little space in between. So what you have in there, chemicals. Where are those chemicals? Presynaptically, that means before they meet the other cell. They have vesicles. When the signal comes through, it actually changes the permeability of the brain cell and opens it up, and you have the serotonin, norepinephrine, dopamine.
Right, so these
all
uptake
these kind of,
inhibitors.
and then it's ions and it's electrolytes. I mean, it's complicated. But to make it simple, okay, basically these chemicals are poured, and you have to have the right code to give the right information to the next one. That's why we call it a neurochemical imbalance, because you might not have enough on the outside of the cell. You might have
Right.
plenty in the inside, but
Yeah.
that doesn't do you any good
Yeah.
because you need it out there, or you might have too much.
Yes,
All
exactly.
right?
Right.
So then there's a mechanism we call reuptake, and that's why a lot of these medications you ask for are reuptake inhibitors. What does that mean? It's like a gatekeeper. I'm
Exactly.
going to close the gate so we can have more available for the brain.
Exactly.
There's
Okay.
too much, I'm going to open the gate and put it back in the cell, so when the next signal comes around, and it's like a pump. You keep this rolling. So a lot of these medications are designed around that. And if you look at antidepressants, and you're right, there's a whole bunch of classes, a whole bunch of them, okay?
Right.
And it's not to say that one is better than the other.
Right.
You know which one is the better? The one that
The
works
one
for
that
you.
works for you.
That's
and
the
that's
best.
something we learned a couple of shows ago. And that's something too. And Jacob, I'm going to throw it to you because you were talking about medication management. So that's part of what you do when you have all these site visits. And that's a great question too, because when you are taking, and I'm just going to throw the number 10. There's 10 antidepressants out there. And 2 of them may work really well, but one's going to work the best. So when you are managing patients' medication, maybe we can talk about the first one that they're trying, and then also someone that you've been seeing for several years, and we're looking at changing their medication. How do you cue in on what it is that you need to do with changing medication, or at least just starting someone on medication?
Well, it depends on the behaviors that the patient is exhibiting. If the patient's psychotic, then we have to look into maybe some type of antipsychotic. Just based on experience, I've seen an antipsychotic called Risperdal work best for the senior population and or the geriatric population. We usually don't try to get too aggressive with the medications because, like I said before, the organs aren't working as fast, the liver's not working as fast, and most of these medications go through the liver, so we have to keep an eye on that. If the patients are aggressive, I mean, we usually start with something. We don't attack the patient with meds, but if they're coming in for depression and anxiety, and they're having some behavioral issues, then we just we start them on an SSRI, which is a selective serotonin reuptake inhibitor, which is what Dr. Rodriguez was just talking about. It helps keep more serotonin in the brain, and then for unknown reasons, the keeping serotonin and norepinephrine in the brain, which are the main neurotransmitters involved with depression, was what helps with depression.
Right. And it kind of keeps a level certain to where there's not the
drop.
So
Yeah,
to speak,
or
that
they're transmitting the serotonin in the brain, and the norepinephrine also is part of the depression. So let's just say somebody's really depressed, and we treat them with an SSRI, and we don't see results, or they're lethargic, or then we can maybe try a serotonin norepinephrine reuptake inhibitor, which is an SNRI, which will sometimes.
and you don't hear about SNRIs very often.
Yeah, there's
Right.
there's not as many as SSRIs.
I
yeah.
see. Okay.
Yeah.
Okay.
So norepinephrine there's got some stimulating properties.
Gotcha.
In norepinephrine, and that'll help wake you up. The only problem is, you prescribe an SNRI, which is a serotonin, it might decrease your appetite. And then in the elderly population,
That's not a good thing.
appetite might be an issue.
Right.
So we got to be very careful. Wellbutrin is a norepinephrine reuptake inhibitor, and it also increases the dopamine in your brain.
Okay.
And then that can cause hallucinations. So it's like a catch-22 for everything. What do?
Right.
We got to think about it. We always go for the simple option. If the simple option works, then a simple SSRI, and if they're aggressive or psychotic, a small dose of an antipsychotic, or which is dopamine receptor antagonists. So they're all neurotransmitters, and then we go from there. I mean, we can't get too aggressive with the elderly population, but it's we have to be careful,
Right.
and then we have
And
to.
so if we're going to look at medications, I think we've hit that pretty well. And if we're in a combination, I always think with mental health, there's a combination of medications and also cognitive behavioral talk therapy, so to speak. Is that something that, again, with your site visits, and I'm going to kind of ask you the same question also in a moment.
Sure.
With your site visits, are there also therapists that you work with, or just individuals in the annex, or just different places that the different sites that you go to that also provide help with talk therapy? And how, again, with the senior population, I completely respect that the organs aren't taking medications as well. So if you're able to do some kind of talk therapy, and I know that's the small way of saying it, cognitive behavioral therapy. Where do you go with that, and who provides that? Is that like who in the system is responsible for that?
No, I mean, I tell every patient, look, medications aren't going to solve your problems.
Right.
You got to make an effort, and therapy, cognitive behavioral therapy, or any type of therapy. I always tell patients, medication might be 40% of treating you, the other 40% in therapy, and then 20% you got to do your part.
Right.
You got to take your meds.
Right.
You got to go to therapy, and that's the great thing about the Hospitals of Providence, the GBU unit. They have activity therapists. They have social services available on the unit, rehabilitation counselors. They have, if we need speech therapy, they're having trouble swallowing.
Right. Okay.
We get speech therapy involved. We have I don't know what else do. If a lot of physical therapy. Everything's available on that unit. So it's a team approach. Me and Dr. Rodriguez will be the first ones to tell you that we can't do everything.
Right.
And
exactly.
it's a team approach. And me and Dr. Rodriguez kind of make sure the meds are going right. We get input from the nurses, the RNs, even the nursing assistants. I mean, they're the eyes and ears.
They're on the front
yeah,
line.
they're our eyes and ears.
I was just having a conversation with someone today. The people on the front line
Yes.
are the people that
Yes.
really see what's happening all day, every day.
And Jacob neglected to mention occupational therapy.
Yes.
Yes, of
I'm an
course.
occupational
Oh,
therapist
yeah,
as well.
yeah.
That's,
Oh, right,
deep to my heart.
right.
That's my undergraduate.
Yeah,
Yeah.
yeah. Well, that makes sense
So-
because it's a repetitive movements, it's repetitive thoughts, it's repetitive everything. And I wanted to bring this up too prior to the show starting. And this is a large percentage. You know, one of the questions is what percentage of older adults deal with behavioral issues? And, you know, and when we say older adults, it's 65 and above. So you guys, one of the two of you were given a percentage of?
Well, actually, if you look at the adult population, it's more like a 26% type
Okay.
of thing.
Okay.
If we're looking at this population, it's right around 20.
And that's a big
That
percentage.
is quite
That's 2
up
out of
there.
every 10 people.
That is quite up there.
Right.
And you would think, well, why younger people might have more? Basically, because oftentimes when you get to that point, you actually, in general terms, might have had a constructive life and whatever. When you actually get in there, is when you're dealing with a lot of these barriers, struggles. Not to mention that perhaps the most common vulnerability is neurogenetic. Genes
right.
play a big role
Right.
in this, you know, so we cannot, it's a risk factor. And a lot of people
Exactly.
think that we inherit conditions. Oh, I got my diabetes from mommy or papi or whoever. You know, no, what I got was the risk of developing the condition. Whether I do or not, it's a different matter. It might do with lifestyle, my diet, alcohol,
combination.
drugs. I mean, all these other things. And to piggyback with what Jacob was saying, you know, all studies to this day show that when you do therapy and you do medicine, you always get better outcome. There's not a single study that shows differently.
Right.
You know, it doesn't mean everyone needs therapy, it doesn't mean everyone needs medicine, but when you actually can justify and use both, you get a better outcome. And it makes a lot of sense.
Of course it does. Right.
You know, because the medicine takes care of the neurobiological, genetically predisposed thing, right? But the therapy takes care of the behavioral psychological component.
Right. And there's skin in the game because they have to participate in
That
the
is
behavioral
correct.
therapy.
That is
you know,
correct.
you've got some skin in
Well,
the
you
game.
learn skills.
Right,
You
exactly.
should anyway, you
Find
know.
your tools.
Coping skills, setting boundaries, issues of self-esteem, issues related to past trauma, whatever. The medicine's not just going to take that away. Yeah, it'll make you sleep better, perhaps not feel depressed to the point that you have death wishes or even suicidal thoughts,
Right.
which is the major risk we have on our field and that we have to be so astute about.
Right. And you mentioned past stress, so PTSD, and I know that's a whole different show in and of itself, but
Let's schedule it.
yeah, we should schedule it, seriously, because we think, just like with dementia, people think the word Alzheimer's. So just like with PTSD, people think automatically something has to do with the military. But there's a lot of patients who experience something in their childhood,
Correct.
something really, really bad that either they're trying to block or just trying to live through it, but things manifest later. And sometimes they don't manifest until they're in their senior years.
That is correct.
So I think that's so interesting that you said that. I want to go back to what you mentioned earlier with genes running in the family. And I say kudos to everyone who's working in the field of Alzheimer's right now, because there's a lot of research out there. And just like in the world of oncology, of what your genes are going to tell you for your risk. And good for you for saying, if you have Alzheimer's in your family or if you have breast cancer in your family, doesn't mean that you're going to get it.
No.
It means that, yes, you have a slightly higher risk.
Higher risk.
And I wanted to just bring that up because I'd like for you to go into that a little bit. For people who maybe have done the autopsy on past relatives who have passed and they have had Alzheimer's, I know that there is now a correlation genetically with Alzheimer's. But how, I guess what I'm asking, what are the questions that you get from patients when they know that they have Alzheimer's running in their family? If there's anything that they can do they wait? Do they just kind of look for certain things? Do they come to GBU, which is a Geriatric Behavioral Unit at Hospitals of Providence? It's hard to get it all together sometime. But what do patients ask you in that realm?
Well, specifically with memory, going back to, most people kind of go there. It's like,
Right.
you know, doctor, you think
Because we
one-
all have those
Well,
issues, so it's easy
not only
to relate to
not
that.
only that,
Right.
there's many reasons why you can have memory problems,
Right.
other than being easily distractible, maybe a little ADD on the side, or whatever it might be. Anxiety can cause cognitive issues.
Right.
Depression can cause. Psychosis can do it. So, you know, aging, it's just
Right.
normal, natural aging. We could be looking at, and but you're right. A lot of people go to the extreme. It says, especially they know about a history.
Yes.
Because you know grandma.
Exactly.
You know, and they might be young enough that you say, well, not really. I mean, even when people have pre-senile type of changes, which does exist.
Right.
Especially when there's other factors to consider why cognitively you see that some impairment. But it's usually gradual enough, like I said earlier, that people might say, you know, this is not going in the right direction kind
Right.
of thing, you know.
Right.
It's a lot more than those kinds of lapses we have at times, or we missed the right exit,
Right.
like I did today.
Oh, well, there you go. That makes me feel so much better. That's good. Jacob, a question for you. So there are specific requirements for a patient to actually be admitted to the Geriatric Behavioral Unit. What is it, and I know it kind of goes back to the question we were talking about earlier about assessing someone, but what is it that a person has to check off, so to speak, on these tests to be eligible to either check themselves in or have a family member check them in? Are there certain specifics, the criteria that you're looking at to be admitted?
Well, first of all, they got to get medically cleared. So if anybody calls a unit, it's like you can call and say, hey, something wrong with my mom. Okay, well then, why don't you get her checked out in the emergency room first? Make sure she doesn't have.
she's fine.
Make sure she doesn't have
Okay.
kidney disease. Of course, now with the pandemic, COVID, they do COVID testing for the seniors, especially because it affected that population. We check the kidney function. A lot of times, the kidney function isn't up to par. Then we gotta figure out what's gonna. It might just be like we said, back to urine. But 65 for the hospitals of Providence. We were trying to get that number lower, but it didn't go through as of yet. But
Okay.
65 central lines. Central lines are lines that go from a major artery into your heart. And then also ruling out infection, just ruling out the medical issues that are involved with what could be causing behavioral issues. And
Okay.
once they're cleared, then they're pretty much cleared to go up to the unit.
Okay.
They just have to be over 65. I mean, is there anything else, doctor?
Well, overall, just looking at it from a more thorough point of view as we do those assessments, obviously some kind of a criteria brought them in.
Right,
It cannot
exactly.
just be the diagnosis.
Yes.
And that tends to happen at times. Well, they have dementia. Can we get into the dementia unit?
Right.
Well, we're not
No,
the
we've got some
dementia
other things
unit
to
to
go-
begin
yeah.
with. There's many things going on.
Right.
But, you know, danger to self or others, paranoia, psychosis, that sort of thing. Inability to actually take care of their own needs, or they don't drink, or they don't know water, and obviously they're going to be dehydrated. And then all of those medical components need to be taken care of as well. Some of it might not be solved completely in an emergency room, obviously.
Right, exactly.
You know, you may initiate the antibiotic for that UTI or whatever, but the behavior might still be there. So, you're not going to send them back home because you don't know how
Exactly.
soon they're going to clear or not. We
And
might
that's
need them in the unit to do
Right.
that and then send them home and that sort of thing. So
And that's where some teamwork comes in as well, because you have the people who are running the unit, but then whoever their primary physician is. So I'm assuming that there is some kind of a teamwork going in there. It's like medically they're okay, mentally they're being managed with medication or not. So how then is, just the same question but an opposite, how then is someone able to be discharged? What are those boxes to be checked off? And that, again, huge question. I know he's giving me this smile like, really?
There
You're
she
asking
goes
me that?
again.
Here she goes. She's asking the questions. And I know it's different with every person. I absolutely get and respect that. Because I'm assuming that with GBU, the Geriatric Behavioral Unit, you don't want to be up there like forever. You want to be
Yes.
up there for a time to manage whatever it is you need to manage, create the tools, give them, like you said, ways to deal with whatever it is that they're dealing with. And so now it's time to be discharged, or they would like to be discharged. What is it that they have to do to make that
well,
happen?
let's start with the average length of stay. It's
Okay.
usually about 9 days.
Okay.
That doesn't
That's
mean
not long.
some people might
Okay.
be there a couple of weeks or 2 months.
Okay.
Or we've had, I guess the record, I want to call it about 3 months or so, and there were other issues legally,
right.
that kind of, but we are assessing those people daily, obviously. We're staffing those people, treatment team, where everyone involved is there. Now that the family could not come in, we have them on the phone or in the video or whatever it may be, so they can participate as well, because obviously they're the best source.
Right, exactly.
When they come in, you don't know those
Right,
people, so
exactly.
you don't know what the level of functioning was before we got them. So we have to assess on an ongoing basis that progress. And sometimes you have to accept how far you can go with that progress.
Right.
Because oftentimes it's a matter of expectations. Not only the family, sometimes ours
Good
as
point.
well, And under the law, basically, you have the right to be ill even from your mind,
Right.
You have the right to refuse treatment.
I like that. We
You
have
know,
the right,
you-
and at the end
you
of the day, we do. It's patient advocacy.
Unless
Yes.
you represent a danger to self or others, or even property. If
right.
somebody's trying to break the unit apart and throwing chairs at the nurse's station or whatever it might be, that represents a danger to self or others, and all
Right.
the property that can be destroyed in the process, right? So you don't really want to send somebody like that to a lesser restrictive level of care,
Right.
to an outpatient setting or a foster home or whatever it might be. So following up that progress and to what point these people will be at a point where they're functional,
Yes.
that's going to be the key.
That's something I should have brought up very early on, because I remember, and I believe it was the last time that we were together, once the mental health issues are interfering with their everyday normal lives, their everyday function, is when the assessments kind of come in. And I remember that,
Yeah.
all these notes that I take, and then sometimes I leave them here like those are the
That's
notes
when
from
it's
2
called a
shows ago.
disorder.
Yeah,
Otherwise,
exactly.
if you don't meet
So
the
if you're
criteria,
finding that you're not able to do what you have done all of your life just normally, that's time to think, okay, I need to get something
something's
assessed
wrong.
here.
Yeah.
So we are about at the 9-ish minute mark before we go. This goes by really, really fast, this program. So what I'd like to do is stop these questions for a little bit. And Jacob, if I can ask you if there was anything that you had in your mind that you really wanted to talk about tonight, and maybe we haven't touched base on yet, or if there's something you'd like to reiterate, what is it that you'd like to tell the audience, or just get that information out?
It'll be quick with me. The basic, the basis of why we work and what we do, what we work, is to improve your quality of life, not your quantity. So you can live to 105 and be miserable, or you can live to 90 and be happy.
Right.
And the other thing is, that wasn't brought up, is cultural awareness. For example, if you grow up in Juarez, Mexico, across the border, and you see dead people on the street, I mean, to them, depression and anxiety is normal. And I've had a lot of experience with that, especially in the jails with undocumented individuals that are there at the jails. I ask them, are you depressed? Well, what's depression? Are you
It could
anxious?
be for them different
Yeah.
than somebody else, right?
What's
right.
anxiety? I don't know what anxiety is, because they grew up with it.
Right.
And so we have to take everybody's culture into, and that's the importance of having a team like they do at the Hospitals of Providence, because we get different perspectives from different people, and we work as a team. As Dr. Rodriguez mentioned, there's a treatment team. We all get, social services is there, rehab is there, activities are there, the patient's there. We also have the family members there, because family is very important in somebody's care. So it's a teamwork effort for everybody. There's a lot of stuff that goes into mental health. And for example, a Latino might think not eating or sleeping too much or just signs of depression are normal. That's just their part of life, and it's just we got to be very aware of that. So,
you know, that's such an excellent point of what is the asterisk of normal.
Yes.
What is the definition of
Yes.
that in any given, especially when you're talking about mental health. When it's clinical and it's medical, you know that the kidney should function between this and this area, but with mental health, that's such a good point.
Yes.
And we're also looking at generations, and again, we're looking at the senior population. They have lived through things, especially someone in their 80s and 90s, they have lived through things that I, as a 54-year-old, have not lived through. And spot on that point. I would love for you to expand on that if you could. So again, perspective, looking at cultural differences, looking at generational differences, because I have a 24-year-old and an 18-year-old, and I think, oh, you guys have it so easy. But in so many ways they don't, because we didn't deal with social media. Social media is a parasite, so that's a whole different layer that we don't understand, and that's a perspective I don't get. It might be a perspective that their 85-year-old grandmother doesn't get. I would love for you to expand on that in any way that you'd like to add.
Sure, and it's one of the reasons we are so proud to actually work in that unit, because we do that. We are looking at all those factors rather than saying, okay, well, it is psychosis and it's psychotic and see you later and so forth. No, you need to look at the person as a whole and what are those needs. Whether it is those cultural differences that we see all the time, especially being in a border city, you have to take that into consideration. Or maybe they moved here from the Northeast, I don't know.
Right.
And whether there's some changes really in adapting, because we do see those as well, where people might live here, but they bring their elderly parents over, and the elderly parents might have some issues, especially if they were quite independent over there, and now here they cannot even drive on their own. Not because they cannot drive, but perhaps because they don't know where to go.
Right, exactly. They don't know where to go. Yeah,
and they don't do the social GPS
Turn left
type
at
of
the
things
light.
and so forth. So looking at all these factors is so critical. You cannot just say, well, this is it, and I have the answers, and let's move on, and that kind of thing. And that's why I feel our unit at Providence is so different, because it's dedicated to this population. It's a unit within a hospital, and most gerobehavioral behavior units that I've worked in the past and so forth, it was a mix.
Right.
It wasn't dedicated for that population. You didn't have a staff that was trained for that population. And that's what makes a difference, when you can really look at the person as a whole and what their needs are, whether it might be a placement issue. So we stabilize that person you asked me about, but now they don't have a place to go back to.
Bingo. Where do they go?
Because keep this in mind, another issue that we haven't mentioned in this population is a lot of them have lost everyone else. A lot of them have no family.
Right.
They might be, like that 99-year-old lady, remember? She had no one. Everyone else had died. And she was cognitively with it enough to tell you.
Oh my goodness.
There's no one in my life left.
So that's
gone.
another question. And I know we're counting down, but Jacob, you brought some things to mind too. I'm thinking about the relationship that you establish with these patients and with other caregivers. And I'm thinking about the receptiveness of care. How often is it that people will think, well, I don't need help, I don't want help? Do you have, and you can just throw a percentage out there on the top of your head what you think of, but are most people receptive to receiving help? Or some people who think that they don't have any issues, but you see the issues and the family members see the issues. How in general does that work? Because I feel like that's a whole nother ballgame too.
Usually the people that go to the unit are hopefully there voluntarily. Every once in a while we have the emergency detention orders where we have to, the El Paso Police Department has to get involved because they're aggressive. But most people are receptive. they're on that unit because they need help and they realize that they have help. And that happens with all age groups. If they're asking you for help, that means they've come to the acceptance that they probably can't do it without medication or probably can't do it without therapy. And I'm going to tell you, everybody has some form of mental health issues, whether it's depression or
I'm a strong believer
anxiety.
in that. Absolutely.
Speak for yourself.
Yes, yeah.
I'll speak for myself.
No, we all.
But you're absolutely right. We all have issues.
Dr. Rodriguez has mentioned adjustment disorders. I mean,
Right.
somebody dies in the family, it's an adjustment disorder.
Absolutely.
We go through depression, we go through anxiety. It's just some people just need a little bit more help, and so they are very receptive. Unfortunately, the stigma attached to mental health is still there, but I'm seeing a lot more people accepting help.
Accepting it,
Yes.
yeah. There's a great book that I love, and one of the quotes in there, one of the questions is, what is the bravest thing you've ever done? And the answer is, ask for help.
Exactly.
And I think that's how we'll kind of stop with some of these questions here. And I want to let everybody know that once we're off the air, I know this goes by super fast, and you can watch this show again and other shows that we've been running for years and years and years. But you can go to kcostv.org. Give them a day or two, and then this show will be posted on that website. And just look for watch and programs, and you'll find the El Paso Physician. Also, the El Paso County Medical Society carries it on their website. So once it's posted on KCOS TV and/or PBS El Paso, sorry, I should say that too. It was KCOS TV when you were on last, because I was looking at our last time here. But pbselpaso.org would be the website. And then also EPCMS, if you think of El Paso County Medical Society, and that one's a .com. YouTube, too. Everyone in the world loves YouTube, so you can also find this on YouTube. Look for the El Paso Physician or PBS El Paso, but I think you can specifically look for it at the El Paso Physician. And I know last week we had a program about people 12 to 17 getting their COVID vaccinations, and for free and very easy and conveniently for you, you can go to the Civic Center Monday through Friday from 8 a.m. to 4 p.m. or Saturdays from 8 a.m. to 1. And you can just drive through, and you just need a parent with you or a legal guardian, and you can get your COVID vaccine, and that will help everybody, and that will kind of get this world somewhat back to normal. I want to say thank you so much to Tenet Hospitals of Providence for underwriting this program, and I also want to say thank you to Madeline, and thank you for watching this program. I'm Catherine Berg, and this is the El Paso Physician. Good night.
This is Masterpiece.
I need to say something. I think our marriage might be over.
So, trial separation?
Except not a trial.
Honey!